Well, it's a pleasure to be here with the Council of State Governments and to be in Rhode Island. I served as Secretary of Health and Human Services in Massachusetts for 3 governors and spent a lot of time in the New England states over those years. In my role at Microsoft, I spend as much or more time in the rest of the country right now, so it's kind of a pleasure to be here. I want to try to focus my comments in the context of much of the discussion we've had, the context of, what does that mean to a state legislator or to somebody in a governor's office or others in government? And how is your role impacted by it, and how can you leverage your position to influence this debate? We at Microsoft are spending a lot of focus and attention at the interface of health, technology, and economic development. And frankly, we're doing that globally. So we think of economic development in different parts of the globe, and vaccinations and getting vaccines to people, and how does technology play into that role? And as was discussed earlier, what's the role of telemedicine and mobile devices in rural parts of the U.S.? We're putting and actually the technology community, in addition to us, the broad technology community is putting a lot of focus on this discussion. We will spend $9.5 billion this year on research, much of that focused on health, or will be able to be leveraged into the health market. We've added about 1,200 people, ranging from policy people to physicians to technical architects and researchers and designers in the last few years, specifically focused on healthcare in the U.S. and globally. I'll talk a little bit about really 2 themes. The policy, as I mentioned, and trying to hone this in on the context of that's most relevant to people in state government right now. Policy, some of the policy themes, I'll emphasize a few. Most of these have been mentioned. I'll put a little more emphasis on a few of those comments. And as well as the interface of technology and delivery system or delivery reform, the primary care themes that have been addressed, and the role of technology in that regard. On the policy, just generally, I want to the reference earlier. We've talked about the in 2009, HITECH Act passed, and the point I want to emphasize here was that was a bipartisan congressional and executive effort. There was consensus on health IT being an important part of improving health outcomes, on being able to measure outcomes and improve them, as well as to reduce cost and assist in driving access to health care. That's important because we're walking into sometimes a contentious health policy debate now, but there was a consensus on the role of technology. Okay. The other thing I'd say is that, and I'll make this distinction between the next 2 bullets there. I've been spending a lot of my time for the last 2 years, and frankly a ton of my time right now, with governors' transition teams as well as legislators in different parts of the country. And the politics in those places vary dramatically on the issue of health reform. So I want to just make a point that I think was raised earlier by Keith. When we start to talk about delivery models in primary care coordination and leveraging technology to help coordinate service delivery in communities, a lot of the momentum in that discussion arose outside of the context. It arose outside of the context of health reform. A lot of these things were moving in that direction. I think that when we look at the current focus on the recently passed health reform, there will be continuing debate, and at the state level, particularly around the issue of the rising cost of Medicaid. Outside of, and again, I'm thinking from the point of view of a government official, lots of concern about the marketplace, the payer, the provider marketplace, but as a in terms of your state budget and your organization of your state services, the cost of Medicaid is a concern that's rising, okay? And it's been framed for some time, but my point here is it'll continue to be a debate because we're talking about dramatic increases in the Medicaid population in the next few years. And even when I was secretary, where I had probably 40% of a $12 billion budget I had was Medicaid, that's growing dramatically. And in the process of growing, it pits for those in government, whether it's the finance, or the Ways and Means, or the finance arm of your legislature, or your health committee, or your finance committee, or the administration on the executive side. It becomes very difficult because it takes available dollars and puts the pressure on what you're doing in education, what you're doing in local aid. So that's the theme there. That's one. I don't want to say the only one. It's a giant theme there. I think that when I looked in what is still in some ways a politically divisive environment around some of the policy around health reform, where I think there's when you listen to what people want, and I'd say this in not only the public but the policymakers. A lot of the noise comes out when you start to get down to delivery system. In other words, the sense of the policy themes that people want to accomplish are the same. They want to drive down cost, that cost curve that was just referenced by Steve. They need to drive that down. That plays out in the context of, we see the discussion around pay for performance, but the concept of paying for performance or improving performance and outcomes as opposed to activities, focusing on outcomes on the consumer as opposed to activities in a provider. Just shifting that focus towards the consumer. That discussion is happening, and frankly, in much of the work I've done after I left Massachusetts, spent a lot of time in a lot of rural states where you've had such an incredible need to act to deal with access issues. You've seen a lot of models originate, as I said, in the midst of and sometimes preceding the health reform discussion. But the benchmarks here will be efficiencies in measuring performance and access. Themes, again, around connecting consumers and providers to health data. If you look at, and some of this plays out of our health reform, but a lot of it, these bullets I'm mentioning below, you've got a ton of, the funding on ARRA, for instance, you had $17 billion funded through, which was very interesting, and I'll get to this in a minute, through Medicare and Medicaid to providers really starting this year, next year, over through 2014. But a lot of focus on that. You had the accountable care organization discussion that was referenced earlier, and the ties to things like pay for performance and medical homes, and how those themes will evolve over the next few years. You have the continuing funding from HRSA around federally qualified health centers. Emphasis, as was referenced, around workforce development and funding to community colleges and foundations getting in the game on that. Funding to community colleges to improve health IT capacities. You have foundations like the Gates Foundation putting giant dollars into that same effort as the administration is in different parts of the country. You've got, and was the reference earlier to funding to increase the number of primary care service delivery professionals in the country. You've got governors talking about the same and some of them doing the same, meaning matching money into some of their community colleges or state colleges or medical schools, and thinking out the question of how do we very tactically and measurably increase the number of providers in rural places, and how are we going to do that in the context of both our role in the state tied to the federal strategies. You've got a real giant question here, and this was also in funded. A lot of funding came out of ARRA, but the question is going to be really two themes here in terms of leveraging the technologies, and one of that is broadband expansion, and particularly in rural areas, but also developments, and I'll get to this in a moment, that are happening rapidly in the mobility world, and 3G to 4G kind of access using mobile devices, and how that impacts. A lot of those developments that will occur in that world have economic development potential for our rural states in addition to health benefits. Because you will, as well as our urban states, but you'll see massive development and applications that will tie to technologies. You'll see governors start to align with groups like Comcast in rural places and say, one of the deals we want to work out with you here is that you put a health channel on here so people can leverage technology to track their own health information. Because you have technologies that can do that now. And a lot of those developments on that technology will come not only because of the efforts in the country, but because of significant efforts in places like India, Africa, and China that they don't have the infrastructure and the political baggage, right? Because they didn't have anything. So they don't have a lot of the, when I say the baggage, what I mean is we have an awful lot of programs in the U.S., for instance. This was referenced earlier on the federal funding side of health and human service agencies where it's been difficult to connect the dots across those systems, even though they're serving the same consumers. So as we think about how do you get a health record and health information for a consumer in a community health center, primary care, in a hospital, and touching other health providers, well, at the same time in the U.S., we have the state health and human service people having TANF, welfare, social services, behavioral health, Medicaid, public health, very siloed technology systems. So, I mean, it's a no-brainer that you would start to connect the information across those as well. And we're starting to see movement in that, which I'll get to. But my point is we also look at, okay, where are we seeing this happen in countries that aren't tethered by that and parts of the world? And so you see a lot of developments occurring. I mean, I was on this topic about 2 weeks ago. Anish Chopra, who's the Chief Technology Officer of the United States, hosted a forum in the District of Columbia, and Bill Gates was asked to speak on behalf of his foundation. And much of that discussion was on giant questions in rural parts of the world. And one of the ones that they talked about was leveraging crises with technology and certain policy initiatives to try to improve outcomes. One of the areas they talked about were children under the age of 5 who died, a subset of those children who are dying. Something like 14 million a year. With the Gates Foundation and some other foundations in some countries, they've dropped that to 8 million just by working, giant efforts on vaccines, but also starting to tie and think going into the future about being able to track populations, identify them, and send them prompts and send providers prompts through mobile devices. Well, to do that, you need access to mobile devices or broadband. So you see giant efforts in parts of the globe that will be leveraged here and are being leveraged here as well. Okay. I want to say something about, I was asked by the National Governors Association in a forum about a year ago to talk about Medicaid, and it's a big issue right now to a lot of the sitting governors as well as the new governors. We did a talk to about 15 new governors coming in about 3 weeks ago in San Diego. And so the point I want to get to is this, and I think it's I noticed that the representative had mentioned to me that she's sitting on Finance and Health Committee. I can't think of the more important place for legislatures to focus and at the interface of finance and health right now. And from a state perspective, looking at the movement in financing and policy and the role that happened quietly in some instances, but dramatically around the role of Medicaid in the last 2 years. By the way, many Medicaid directors have not caught up to this discussion yet, all right? But I'll mention a few themes and then show you a picture that I think sets this up a little more. You have the insurance exchange discussion that is coming out, start 2011, insurance exchanges in 2014. But interestingly, again, from the point of your Medicaid agency, the eligibility to determine eligibility for health insurance through a health portal and an insurance exchange, that eligibility capacity and technology functionality will be driven out of your state Medicaid agency with 90/10 funding from CMS. Now, that's not just a financing question. It's a significant policy issue because now your state Medicaid agency, as a payer, is being financed to set up and to interact in a different way, more intensely in a different way with the commercial payer marketplace. So the Medicaid is heavily into that, will be heavily into that. Similarly, the $17 to $20 billion funded on electronic health records was determined that the funding would again go through Medicare and Medicaid down to the provider industry, even though that's a commercial health marketplace it's going into. Accountable care organizations pay for performance themes, as was mentioned on Vermont and North Carolina and a number of other states, some models that have developed with Medicaid agencies around how they're thinking out delivery of care to their most at-risk populations and leveraging not only technologies but finance strategies. For instance, on pediatricians in New York State, the legislature and the state Medicaid agency is focusing on how do we incrementally incent care in the community and get primary care focused in the pediatric community because we have a shortage on that. And I mentioned a dramatically expanding population. CMS has a MITA architecture, which is, for purposes of this, because it could go down a sinkhole in terms of the amount of time it would take. But what that really means is it's an architecture that allows you to take disparate technologies and think of how you can connect them to share information. So you may have a welfare agency and a Medicaid agency and a hospital industry. It's like the health information exchange thinking, which allows you to think of connecting information across the top. And then you've got models that are starting to develop around the country at community health centers, at the interface of health and education. In Florida, we've been involved in a number of efforts that create medical homes in schools. When you think about rural health, it's not just the delivery, it's the locus of care. So you're going to be leveraging, as was stated earlier, you're going to locally leverage services, but you will leverage telemedicine and other technologies that will bring that in. Similarly, however, you will see the development and reuse of locations of service, regional schools. Okay, you're going to start to think about places where people are, and many of you are doing this now, but we're seeing the development of that. Medical homes, school-based medical homes, leveraging education and health strategies at the same time. Minute clinics, obviously you're seeing the commercial marketplace, Walmart and others starting to get more and more into the discussion of recognizing the gaps in certain primary care and the business opportunity from their perspective and the development of services and locations, including the different commercial markets. I just want to show you this because this was about 3 years ago. Right when the ARRA High-Tech Act passed, I was dealing with some people with CMS, and it was before the regs came out on it, but we were talking about this question of how interesting it was that Medicaid and CMS was being so integrally put into the center of the development of commercial and public sector health care. So we spent about 5 months where we did 5 visits, meetings in different parts of the country, rural and large state, at the behest of the governor of each state or their legislative or agency leadership. And then they asked me to come in with their people, and then in addition to that, they asked CMS to come into the state. But this picture came out of some discussions we had with Governor Manchin in West Virginia, as well as meetings in New York State, and with Governor Riley's team in Alabama, and in Wyoming and in California. And I won't spend a lot of time on it, but I just want you to give you a sense of how different this world is in terms of state government and why it's essential, if you're a state legislature, for instance, that you get very close to what Medicaid is doing or can do. Or both from regardless of where you stand on it, whether you want them to be more involved or less involved in this policy debate, they are increasingly at the center of it. That's hard to read, but that's just a list of all the different, not all of them, many of the different health and human service agencies in the state, okay? TANF, Elder Services, Medicaid, mental health, behavioral health. In the last 4 or 5 years, you've had MITA, which is this CMS Medicaid architecture, which devises a strategy to connect information across systems, okay? The picture on the top is actually our Connected Health Framework, which basically sets a technology blueprint that allows you to do that. With the passage of health reform, and by the way, in this picture, as I say, CMS is also playing, Medicaid is very essential to this discussion because your state agencies, in terms of your funding for IT efforts, your largest ones are going through your Medicaid agency. And you get a 90% federal match coming through your Medicaid agency. So the question that starts to arise here is, can you start to build out technologies that will serve multiple systems through your Medicaid expenditure so the state spends less and it's more efficient? You're not rebuilding things in all those systems, okay? Now with health reform and ARRA, now you have Medicaid increasingly central in the commercial marketplace, healthcare delivery marketplace. On the agency sides, CMS and ONC and HRSA and the different agencies, but now also going down to the payers on insurance exchange, the providers on accountable care organization themes or EHRs. All of these things start to connect in terms of policy and financing, and Medicaid's right in the center of those. So, I mean, I had a discussion with a governor recently who said the number one thing I got to do is get clear on what I'm thinking for Medicaid director. Because they better have a finance sense, they better be able to talk to the legislature, and they better get a sense of the national policy and the state policy. Okay. Some of the themes on rural health, and I'm going to go through these quickly because I think, frankly, they're repetitive to what was stated earlier. A clear pressure on rural primary care, emergent expansion of providers and service models, some of which didn't exist in the past. Patient-centered models of care, models that connect health, human services, and education, importance of workforce development, I would say economic development, role of education, including the college systems and community colleges, and then leveraging advancements from broadband to mobile devices to cloud applications. I don't have time to get into this picture other than to say this is a picture that is very similar to the MITA architecture. It's important if you have a state CIO and a Medicaid director and a CIO there, that they're able to say to you in the governor's office of the legislature how that picture works for the future development of state IT and how it relates to the commercial health marketplace. And I could talk to you further about that, okay? But it gives you a sense of basically you have siloed agencies. Now you start to think about how do we develop technologies that are much cheaper, right, but that would allow us to start to connect information across them. On the rural health disparities and technologies, a lot of these are existing technologies. I'm going to make a point because I think this is pretty relevant. Technology can actually improve health outcomes. It can also raise costs, depending on how you're doing it, okay? I mean, a lot of those big legacy systems are $200 and $300 million systems without any reference to connecting across them, all right? But what I'm trying to get to here is thinking in the context of a policymaker around how do I drive, can you tell me how to improve outcomes and drive efficiency? If you ask the question, can you tell me how to improve outcomes, you do not know if you're going to get efficiency. The answer may dramatically increase spending. Okay, so I would go back to those policy points of access, efficiency, and outcomes. The existing tools that get to that are broadband, collaboration tools, and video conferencing, the telemedicine themes, the rapid development in the cellular phone industry and how that's starting to play. Electronic health records, HIEs in the development in states like Vermont. Developing technologies. We talk about cloud, meaning rather than have to have your applications, your technologies built in all these systems, you leverage the internet and have them stored in the internet, serving multiple systems at the same time. Governments are rapidly moving to that. Personal health records. We're dealing with Medicaid agencies, for instance, that are saying we don't want to wait for health information exchange to be completely developed. We're now going to move all of our Medicaid records for a consumer into the cloud, into a personal health record, and then think about how they might also move some of the other human service data in there. So when a kid who turns 21 from social services or juvenile justice leaves, they have a record of their role in government. They know their social, and these kids don't even know their social security number. But you also have key themes for them. Their personal, their pharma stuff, some of their health, other relevant health information, and some of the other agency information. Security, privacy, digital rights. I would ask that question always because a lot of times people shoot from the hip on this, but I mean, you see this in other parts of the globe. If what technology is doing isn't secure, you're going to have a giant problem, particularly as it relates to health records. And also, the emphasis can be placed, and I think should be placed, on accessibility, particularly when we're talking about health and human services. And since there are low-cost technologies that allow you to ensure that disabled persons have access can leverage the technologies. Finally, on considerations for state leaders, it's here. The technology is not the issue, really, in this discussion. It's here. We do it. Our partners do it. And our competitors do it. It can be leveraged if you focus on the policy themes I referenced earlier in terms of access, outcome, and efficiency. Think about the role of state Medicaid. I might be stating that heavy here, but it's because there's government leaders in the room. And it's your biggest driving spending part of your government, but it's also at the center of so much of this debate. Workforce development, as was referenced, models are occurring in the rural states and will be duplicated. Think about the interface of health and education, and particularly some of the themes around cohorts of kids and the school lunch themes and obesity and vaccination themes and all of that, where you have school nurses. You can start to leverage those resources pretty easily in primary care delivery models with medical homes right in the schools. And then also the interface of commercial public sector health and how that relates to the intersect of government-funded health and human services. I'm late, so I'm going to end it there. Thank you.